I want to start out this morning and perhaps revisit a discussion that we had yesterday. And I think we had many good discussions yesterday. But I do want to go back to one and talk a little bit about the National Strategy for Biodefense. And we were very fortunate yesterday that we were able to have Tim Morrison straight from the White House Situational Room to roll out and talk about this new national strategy, which is really a very significant milestone. And part of how that really was catalyzed, we can go back and actually there's been several reports, several studies, including one of our policy papers that emanated from a summit that our summit from 2 years ago that made recommendations that you can see the forensic evidence in this new national strategy of how the deliberations at our summit influenced that national strategy, but there was also a PCAST report that had influence in it, and the Biodefense Blue Ribbon Panel study also had some influence in it. And some key things that perhaps all these reports talked about was the importance of leadership, and leadership at the highest levels. And without a strategy and an approach and a vision, it's hard for leaders at all levels, because we did talk about yesterday the importance of leaders at all levels. And so that leadership at the highest level is very critical. It is very critical for setting that vision and approach and strategy, so that the leaders at all program levels and at all levels of government and in the private sector and academia know where to go and know how to apply resources and how to make some priority decisions. And so I celebrate that this national strategy is now out. And I'm going to work very, very hard to help support this new national strategy in any way that I can. And I think where the rubber is going to meet the road with this new national strategy is in the implementation plan that's going to be following. And that's where it will be critical. And so that is maybe one area that I want to perhaps speak about a bit. And then I'm also going to ask a couple colleagues if they have some additional considerations or thoughts about the national strategy. And I can recall when I was at HHS, and actually Andrew was USAID, and when the Bush 43 administration began to get real serious about H5N1 preparedness. And John Barry's book, in fact, was required reading. The Great Influenza book became required reading for the cabinet. And the end result was ultimately an emergency supplemental that went from President Bush to the Congress and resulted in, I don't remember the exact number, but it was in the order of $6 billion, $7 billion emergency appropriation for pandemic influenza preparedness H5N1. And that started a cascade of events that first was a strategy of how we were going to implement this emergency supplemental. And actually that strategy was first being drafted in a cabinet department called HHS, where I happened to reside at the time. At some point, the White House pulled the writing from a department cabinet, pulled it back up to the National Security Council, and put a team together to actually finish writing this strategy. And soon after that and it was about like a 15-page document, high level, but it did provide a vision and at least a strategy and what the things we were going to be covering. But importantly, really before that strategy was released, a team was built within the National Security Council under then Special Assistant to the President for Biodefense, Rajiv Venkaya, and people were pulled from the 8 department agencies to put together an implementation plan. This implementation plan included 300 action items. It clearly identified who had lead and who had supporting responsibilities. It had milestones, metrics, and at least every year our deputy secretary and secretary had to brief out Fran Townsend, and she had to brief the president on progress. So there was accountability, there was tracking, And it was clearly identified in this multidisciplinary whole of government, whole of society approach, how to move forward. And so if I had if I had an opportunity to make a recommendation to the administration as they embark on this implementation plan, I would strongly ask them to go back and at least take a look at that approach of how we did that implementation plan. I'm not saying it was right, wrong, but it worked. But I also think that in reflection that the pandemic influenza with a discrete budget was probably much easier than what biodefense will be. Biodefense, if many of you know, is separate appropriations in many departments. We talked yesterday, it was stated there's at least 16 department agencies. The last time in fact in our report, we had over a dozen, so I think maybe it's metastasized a little bit. And there's over 50 Senate-confirmed individuals who have some responsibility for biodefense. And there is no single budget for biodefense. In fact, I think it would be very challenging for somebody with inside government to actually tell you what the number is for the biodefense budget. To date, the most kind of credible source that I've seen that at least makes a good estimate for what is the biodefense budget comes from research and analysis from the Johns Hopkins Health Security Group. And they usually publish an annual report of what is the U.S. government investment for biodefense. And I don't remember the exact numbers, but it is on the order of, on average, and counting some of the spikes and counting the BioShield appropriation, close to $80 billion since the early 2000s. It's close to $5 to $6 billion annually. But again, our best estimate of what the biodefense budget is coming from scholarly research outside the government, not from the Office of Management and Budget. So I think the biodefense challenge will be even harder than the emergency supplemental pandemic preparedness that we began to embark on back in the 2006 timeframe. But anyway, that was one of my thoughts and one of my considerations and perhaps recommendations. At least go back and look and try to take some of the lessons observed, lessons learned during that period to guide how the implementation plan of this new biodefense strategy might look like. And yesterday we had a few conversations about leadership and commitment, focus within the National Security Council, our Department of HHS, and I think we're very, very fortunate on the one hand with the recommendation that the Secretary of HHS and the Assistant Secretary of Preparedness and Response at HHS will have a lead role in this implementation plan. I have complete confidence in Secretary Azar and Assistant Secretary Cadlick. But I also have concerns about, will other department agencies back away a little bit? Will they believe that, well, since HHS has the lead and they have this budget for emerging infectious diseases and biodefense, does that mean we can decrease our budgets? I don't know, but I do have that concern. And I think that was part of the richness of our conversation yesterday about leadership at all levels is very important, but it starts at the top. It starts at the highest levels. So I wanted to ask a couple colleagues in the audience who've actually been in the thick of it to see if they had additional considerations too about this leadership, continuity across administrations and so forth. And so Ken Bernard, and if there's anybody new in the audience today that was not here yesterday, Ken was the first Special Assistant to the President for Health Security and Biodefense. So Ken, if you have any thoughts or considerations or anything that you would like to recommend to our good friend Bob Cadlick or Tim Morrison.
Yes, thanks. For those of you who were here yesterday, you heard my point of view pretty clearly, I think. I think the strategy is fabulous. It's fleshed out what we did back 15 years ago, as we were required to do our strategy in very brief, much more brief format, weren't allowed, for example, back in the Bush 43 days, to have a presidential policy that did anything other than give instructions to cabinet secretaries. The president would only say, the Department of Defense or the Secretary of Defense shall, as opposed to going down into the agencies and saying CDC will do the following or USAID will do the following. We were under pretty strict orders in that regard, so ours was pretty general. This new one is, because of the way we change data, we move data around now, is much better. It's much more complete. It's much better thought out. The emphasis I want to make is that oversight and leadership are not the same thing. Unfortunately, the presidential memorandum lays out that supports this document or orders the implementation of this document has devolved the responsibility for the oversight of this primarily to Health and Human Services. Now, they do say that the Secretary of Health will report to the NSC and to the President, and there's White House oversight of the Secretary. But the day-to-day negotiations of who's going to do what and the taskings that you suggested related to flu will still come out of HHS and out of this committee. And I have concerns that other agencies, as you do, other agencies will fail to take them as seriously as we would all like them, based on the location of the oversight. The other thing that the memorandum does is it adds what I consider a fairly egregious number of reports to committees, to Congress, to the President. It looked to me, if I were trying to design an oversight process, I'd have to hire 5 or 6 people just to write the progress reports. And I think it's way overdone. I think we need to get to work. We all know what to do. If you look at the new strategy, it's no different than the one 15 years ago. It's just fleshed out. It has a few more things added based on biotechnology and synthetic biology and such, but it's basically the same idea. Prepare, protect, defend, deter, research, etc. The difference is that there seems to be kind of a lot of micro-managing and oversight out of this committee at HHS, and I think it's going to not be the best approach to move forward. I'd really like to see an assistant to the President whose full-time job is dealing with the biosecurity, biodefense portfolio, and barring that, maybe a deputy assistant to the President, and if need be, a special assistant to the President whose full-time job is dealing with this immense portfolio. And in addition, there needs to be a cross-cutting Office of Management and Budget person who does nothing else except the cross-cutting budgets across multiple appropriations committees, so that we end up with a fully funded, budgeted, well thought out support for the policy, because policy without budget is shelfware.
Thank you, Ken. Beth, do you have any thoughts you want to?
Following Ken is always a hard thing to do. No, so the first point I was going to make is the last one that Ken just made. So I'll first say that I too think that the National Biodefense Strategy is an excellent document, and I think that it's welcome, and it was definitely time to do an update. I had the privilege of overseeing implementation for a PPD2, sorry, which is the Obama National Strategy for Countering Biological Threats, which was explicitly under PPD2, sorry, which came under HSPD 10, and the Obama administration kept the Bush administration on the books and explicitly added to it. So those two documents were actually appended to one another in the Obama administration. And that document had a budgetary piece to it where we sent budget guidance every year. And one of the things that was always challenging was having follow-up to that budget guidance. And so the number one thing that I think many people wanted to see in the new strategy, and it has potential, but it is not nearly as fleshed out as I would have hoped, and I can understand the reasons why that might be, is an explicit link into a specific person or piece of OMB that makes it more clear how the budgetary oversight will take place, and how the information that's prioritized in the implementation plan will actually make it into the president's budget, because that's where it becomes challenging. Departments and agencies can recommend all they want, and the working level folks, like I was, who are organizing meetings and bringing people together, can prioritize as much as they want. But if the National Security Advisor and the Director of the Office of Management and Budget, and ultimately the President, don't decide this is a thing that every year they're going to prioritize, it won't matter, and it won't make it into the budget. So that's number one. Number two is, as a related point, I think one of the key challenges with this strategy, because it rightly brings together, as Congress requested, the global and the domestic implementation of countering biological threats programs in the United States government, it will make it harder to make trade-offs between funding for things in the that actually physically go to the United States versus funding for stopping outbreaks at the source, where the funding actually flows overseas. And I do think that's always a challenge, and of that approximately $5 billion annually, a very small fraction of it goes to programs that help build capacity to help stop outbreaks before they spread. And that's approximately $500 million or less a year, spread between CDC, USAID, DOD, and a small amount at State Department, and an infinitesimally small amount at FBI. And that budget crosscut is, it grew with the supplemental post-Ebola, and if it doesn't come back up to a level close to what I believe it should be, I do think that there will be challenges, and we will lose some of the great people who are overseas helping work with other countries, which was a great outcome of that Ebola supplemental. So that's a concern that I have, is how those trade-offs will be made between the White House and OMB. And then just finally, you mentioned implementation, Jerry, and I think that the implementation plan, in the Obama administration, we talked a lot about elements of HSPD 10 and PPD 2 that might need an update at some point. And a timeline with specific goals and very clear direction for departments and agencies to come back to the White House to fill gaps. There was definitely an understanding of what some of these big gaps are, and like Ken said, it's great to see them better outlined. But what we really need coming out of this, and we have all the tools in this plan to get there, is a prioritization and funding to actually fill those gaps that we're talking about here at the summit. And then just lastly, I do think that I would have liked to have seen more clear direction, not only for the high-level person to be responsible in the White House structure for policy, but also whose job is it to be the oversight coordinator, not to actually do the response, but the coordinator for the response. And I believe fervently that needs to be at least a deputy or above.
Thank you, Beth. You make an excellent point about the global international aspects of stopping an outbreak at its source, and that is going to be a critical. And we talked a lot, actually, in the One Health panel yesterday. Really, what came out of that is there needs to be much more focus on international and the capacities and the technologies. It's absolutely vital that we stop these outbreaks at their source. We're not going to stop an outbreak. Outbreaks will occur. It's what we do when an outbreak happens that can prevent an epidemic or a pandemic. And so these international investments and trade-offs are absolutely, the international investment is essential. Everything really can kind of be boiled down to priority and focus on this leadership question, I think. And so that's going to be, I think, an area of rich continuing discussion as we move forward. So I do, I went in on a high note with the national strategy because we need to celebrate it. It is an indication that the administration, actually Congress catalyzed, actually these policy papers and that many of us have been a part of, including the Scowcroft, have helped catalyze Congress to actually call for a national strategy, and the administration has done that. And it is really the first time, it is comprehensive, it is the first time that we're essentially looking at all biological threats, whether they're naturally occurring, intentionally released, or accidentally released. And it is looking at a One Health approach. Even though you may not see the word One Health in the strategy, it is looking at across the human, the animal, environmental domains. And it does mention the domestic and the international components of this. But it will come down to an issue of priority and focus, and having focused leadership at the highest levels for those of leaders at all levels of anywhere you find yourself in the biodefense enterprise, so you know exactly which direction you're moving in. Another critical thing, I think it does mention where in the United States anywhere, the front line of biodefense, emerging infectious disease, and pandemic preparedness actually is at our local public health. And there is mention, very rightfully so, that we need to do more at the national level to support and bolster and make sure that our front line at the state, local, tribal level of public health is strong and vibrant. And I can speak with my experience here in the state of Texas. We have a very strong public health program and a very strong emergency management effort just here in the state of Texas that is tested time and time again, whether it's a natural disaster or Ebola arriving in Dallas, Texas. And it has risen to the test time and time again. And with that, it's my honor, we're very honored that we have the Commissioner of Health from the state of Texas, Dr. John Helerstat, who is going to join us today and share some of his thoughts about public health in Texas. So, John.
Thank you, Jerry, and howdy, y'all. Howdy. This has been really an amazing experience for me. This summit is quite remarkable. I didn't have any idea there were so many brilliant people from all over the world, all over the country, all over the state, who spend the focus of their professional lives worrying about and planning for and doing their very best to mitigate the consequences of serious disease. And in this case, we're talking about an influenza pandemic. So, looking for my, do I change my own slides, or how does that work? All right, okay. You know, I feel like I've been really in the role of a student here, learning. And so think of part of my presentation anyway as a summary, like, well, what did he learn? What did the student figure out that he didn't know before? Think of it in that light. Yesterday morning, you know, one of the themes was looking back to look forward, and I think that's really, to me, a very powerful paradigm of how to understand and how to go forward with this, and so that's going to be a part of what I'm talking about here. Okay, sorry, we're on the second one. I don't do this for a living. I just want you all to know that. So here's a summary of what I'm going to be talking about. We're going to look at a global and national state overview, the rapid rates of mortality that we saw in 1918. And in particular, I'm very fascinated by some of the presentations yesterday morning where, if you will, very well-informed scientific minds of the day back in 1918 were worried that we were on the edge of essentially socioeconomic collapse. And I think, to me, that's one of the things I worry about. as well. My perspective on this is informed by a couple of different experiences in my life. One, Zika, where I was very much in the forefront of what was going on in Texas and Zika around the country. The other was the Ebola crisis in Texas in 2014, where the memory of that lives on in my agency, and the lesson was really all about what happens when the public panics or gets anxiety to near panic. And the other would be the 2009 H1N1 pandemic, where I was the chief medical officer for a children's hospital in Austin, and saw how it was that we responded to that demand. And then the other was Hurricane Harvey, where one of the biggest lessons I learned was all about preparedness. So, as we know, this marks the 100th anniversary of what was known as the Spanish flu. There's some debate about where the name Spanish came from, but again, as we heard yesterday, a lot of people would tend to just name the flu on whoever they thought caused it without any real reference to what was really there. Back then, the Earth's population was about 1.5 billion, and there's some estimates that a third of the population of the Earth was infected. And by the time the 1918 flu subsided in 1920, tens of millions of people all over the world had died. In Texas, we estimate that there were about 20,000 deaths. And by the way, these are archival photos that my library science folks found for us that are authentic from the archives in Texas. And so more than 20,000 deaths, 1,800 troops. That would be a large number today. If you extrapolated that out, that would was back when the state only had a population of about 4,600,000 people. So again, if you do the extrapolation, you're talking about lots and lots of folks. In September 1918, hundreds of cases suddenly appeared at Camp Logan, which was just outside of Houston. Camp MacArthur near Waco was hit hard with more than 900 cases, and more than 200 soldiers died. Nearly 500 civilians died in Waco itself. By October, Dallas leaders were working with Army officials to quarantine troops at Camp Bowie outside of Fort Worth, and Parkland Hospital overflowed with flu patients. More than 800 died in Dallas. San Antonio ultimately reported 12,300 cases with nearly 900 deaths, though there were likely tens of thousands of other cases that did not get reported. And El Paso reported 131 deaths in 1 week in October. This slide shows excerpts from the National Public Health Reports in the fall of 2018. The reports, the weekly reports from the beginning of the pandemic, I'm sorry, this should be 1918. The weekly reports in the beginning of the pandemic had brief influenza prevalence updates for each state. These are the ones for Texas. They illustrate how quickly the disease spread. By November the 8th, public health reports started showing the number of cases in a table format by regions, and went on from there. On slide 6, you kind of see a summary of the, essentially, if you will, a projection of what happened in 1918 and what that would translate into in 2017 population. So over the United States and throughout Texas, San Antonio, and Dallas, really the death rates remain the same. But if you projected that into 2017, death rate, number of deaths in Texas, it would be 155,000. And of course, last year, I believe the CDC reported about 80,000 rather, deaths across the entire country. So you can see what a pandemic with a fatality rate anywhere near this would, how disruptive it would be if projected into the future. And so one of the things that, again, absolutely fascinates me is given that a very well-informed scientist of the day back 100 years ago said to himself, wowee, how are we going to survive this? if it keeps going at the rate that it's going, this is catastrophe, true social and governmental and political catastrophe, as well as a health catastrophe. But they made it through somehow. And so what was it about that? And are there still lessons that we can learn from it? And I think a key to it was in 100 years, our capabilities are vastly different than they were then. But some of the capabilities they had then that enabled them to survive and get through it and cope with it are still with us. In other words, some of the basic principles of public health. Secondary infections, obviously, were a major problem back in 1918. They not only had no antivirals, they had no antibiotics. Secondary infection with Haemophilus influenza was a leading cause of death. Today we would have antivirals, today we would have vaccines if we got them into people fast enough, and we would have antibiotics for the secondary bacterial infections. But that, in a way, kind of again brings to mind the experience that I had in 2009 in a children's hospital. So we had a particular capability, i.e. the capability of an emergency department. But we knew that the demand would increase. So what were we able to do? We were able to grow the capacity of that emergency department by getting inflatable tents. It was a great media opportunity, by the way. But we had inflatable tents where we triaged and treated patients. The flu itself, however, was, as we all know, not an especially virulent flu, maybe even one of the milder ones. So even though we saw a much increased demand for the outpatient, if you will, entry into the healthcare system, that didn't translate in higher rates necessarily of kids having to be admitted to inpatient care or especially into intensive care. And so that, again, is a really something that I keep in mind, because we could scale up a capability like emergency department, but if it had been just a little bit more virulent, we would have exhausted our capability in the inpatient beds and in particularly the ICU beds. And I think that paradigm is something that that has really resonated with me in my thinking in this seminar. In 1918, we had really almost nothing to prevent or combat it, again, except for the basic public health principles that were talked about. Quarantine, isolation, shutting down public gathering places. But of course, obviously, those had socioeconomic consequences as well. And if you took that to the extreme, people wouldn't be able to go to work and the economy would grind to a halt, which really isn't very good for people's ultimate health either. The capabilities that we have today that are vastly different than what they had 100 years ago, even just the simple stuff, we have the antibiotics, we have the antivirals. They didn't really even have IV fluids or things like that. The capabilities that they had were only the ones that people could provide essentially in person. Someone could nurse you, someone could try and encourage you to take fluids, encourage you to have nutrition. And those capabilities were very widely spread. In fact, if you will, arguably, they were universal throughout the country and throughout the world 100 years ago. And those kind of capabilities, arguably, would still be very, very widely available. In the absence of vaccine, the only real prevention, again, was public health. That's a picture of a device that was used to disinfect throats and nasal passages in soldiers at Dallas Field Aviation Camp. Again, I'm mindful of one of the points that was made yesterday about the fact that one of the goals maybe for new vaccines or new modalities to prevent would be to have mucosal, increasing mucosal immunity. So I think of this as kind of a really misguided and perhaps worse than doing nothing at all attempt, though, to try and create some nasopharyngeal immunity. We talked a little bit, there was the beginning of the germ theory of disease, but it wasn't really widely disseminated the way it is today. I mean, pretty much everybody understands the germ theory of disease. Back then they didn't. They thought it was generally just dirt or filth or dust or things like that. And so in some places, like for instance in Dallas, the mayor recommended a cleanup campaign, which may have been worse because it kind of put people together in community cleanup campaigns in a way that may have increased the spread. Again, thinking about the 1918 response factors, there was a call for cleanliness, for general hygiene, and there's not really anything bad about that, but it wasn't specifically focused on what we would think of, which would be proximity, droplet spread, and the like. So I talked a little bit about the capabilities that they had back then, i.e. direct care from person to person. But obviously what happened even then was the capacity to provide that got exhausted. And so in many cases there were shortages of doctors and nurses, and just as today there were great disparities in terms of communities' access to health, and once those resources became even more sparse, African Americans, Hispanics, and other disadvantaged communities often didn't even have access to those fundamental, or if you will, basic kinds of capabilities in their communities. Then, as now, there was public skepticism concerning the seriousness of the flu and the need to take actions to prevent it. I think that's really amazing, and again, it kind of points out a tremendous difference, I think, that would be very, very probative, if you will, if a pandemic were to take place today. Back then, they had newspapers. That was essentially it: newspapers, telegraph, as a means of communication. Today, of course, not only do we have radio and television, but we have the incredible phenomenon of social media. And social media is the source of news and information for what is approaching almost a majority of Americans. And of course, as we know, social media can be a great source of information. It can be a source of misinformation, and it can also be a source of disinformation. And so whatever happens in terms of the public reaction and attitude towards any kind of pandemic threat in the future is going to be shaped through those types of media and that type of communication. Communication, as we all know, is extremely important. I saw communication, if you will, succeed in the Zika crisis that we faced in Texas. We spent a lot of time making sure that from the CDC through our state level Department of State Health Services and down to our city and county local partners, that any time we had what we believed would be local transmission of a Zika virus, that we all got together on the phone, we all shared the same facts, we all did as much as we could to come to the same consensus and conclusions, and therefore say the same thing, have the same message for the public. And getting that message out first and foremost, and not trying to pull the wool over anybody's eyes, is the absolute key to coping with it. Because the minute the public knows, and they can sniff it out, the minute the public knows that you're not leveling with them and telling them the truth, you lose credibility, and therefore you lose the ability to influence their behavior. I'm going to sort of flip through this. I'm keeping an eye on myself. What slide is it? That's 18? All righty. Did I miss the vaccine? What do I have to put that here? Okay. Again, I don't do this for a living, so please bear with me. Here we are looking at basically the kind of preparedness that we have today. That was one of the lessons that I learned again from Hurricane Harvey, is that we were as successful as we were because we were prepared and because we practiced that and were able to put that into play. I think there's a different version loaded than what I have. So, there we go. There's our vaccine coverage rates, which I think ought to give everyone pause, because as we know, the vaccines aren't that perfect, and even so, we have even fewer people getting them. I was able to get my picture taken getting my flu vaccine at our headquarters last week, and of course the message is that we all know, as imperfect as it is, it's something that the more people we get to take the vaccine, the less likely there is to be very widespread disease. So I'm not quite to the end, but I think I've really pretty much covered all of my major points. And the takeaway for me, again, is that if we have a pandemic, and all pandemic means, as we know, is that it's widespread, and we had a pandemic in 2009, but it was a low virulence organism. If we have a pandemic with an organism that's even slightly more virulent, like I said, my experience in the Children's Hospital was we could gear up our capacity for the capability of providing emergency department, if you will, treatment and triage. But if there had been more virulence, that would have spilled over into the need for more inpatient care, more inpatient beds, more ICU care. That is not something that you can scale up very easily. And again, comparing it to Hurricane Harvey. Hurricane Harvey was this incredible, if you will, battle space that was 300 miles wide, 100 miles deep into Texas, and 60,000 feet high. And as amazing as that was, it was still regional. And so the affected region had the rest of Texas and the rest of the United States at its back. If we have a true pandemic that's global, it's certainly going to be national, and it means everybody else is going to be coping with the same problems, and when their capacities have become exhausted, they will not have capacities that they can give to us, and vice versa. And so that makes for, that to me makes for a very scary kind of thing. So I'll wrap it up. I think the thing that is, from my thinking, going forward to how best to be prepared, is to ask ourselves, what are those capabilities that are already the most widely dispersed or most widely available, or what are the capabilities that could rapidly be widely made available and widely dispersed, and whose capacities could be scaled up with sufficient timeliness to actually have an impact on the pandemic. Because if we get to the point where certain capabilities are exhausted, like the capability of putting people in an inpatient setting, for heaven's sakes, if we think about the numbers that are potentially there versus that resource, that capability, that could easily be exhausted. And essentially, once you've exhausted a capability, then you don't have it anymore. That for the next person who needs it, it's not there. And so the first person who would succumb to a flu pandemic for lack of access to something like a ventilator or an ICU or even just inpatient care, that'll be news. When the 1,000th person succumbs to the flu because of lack of access to those higher level, more technologically sophisticated capabilities, that will be a crisis that we have to deal with. So again, I know this is pretty basic stuff, but hey, I'm a student, so I get to know pretty basic stuff, right? We need to get as far upstream as we can, but we need to think of that in terms of what are the things that are widely dispersed, what are the things that are rapidly scalable, and some of those things are exactly the same things that happened in 100 years ago. In other words, the basic public health principles of confinement and control orders and again, controlling the access that people have to one another in a public setting. So I think, didn't really stay on my slides, but thank you very much. I appreciate it.
Please, I'm sure the commissioner's open to taking some questions, so I know I have one, but I'm going to let the audience have the prerogative.
Yes. Just
me
step
or
up. You were first? To the left, yes.
Happy to go in whatever order. I really appreciate your comments about scale. I was involved with the federal Ebola response, and one of the big challenges we had was figuring out which tools scaled and which did not on an appropriate timeline, so it's really good to see that called out in your presentation. A question for you about the structure of healthcare provision in the United States and how that relates to a kind of command and control process in a large-scale pandemic response. So, you know, the U.S. uniquely in the world has a very decentralized system of health authorities. You know, not like the NHS in the U.K. where they can decide at a national level what the policy will be, and then the NHS rolls it out. How do you see that? How do you see that dynamic playing out, and potentially, how do you see us managing that dynamic in a major national and global pandemic scenario? How would you, as a state health commissioner, you know, what would you look to the federal government for? What would you want to preserve as your own authority at a state level? You know, during the Ebola response, we saw a lot of different approaches from state to state on things like travel controls and quarantine policy and other things like that, and it created a lot of confusion. So curious how you think that should be handled in a future event.
Well, that'll be the challenge. That will be the incredible challenge. And like I was saying, that the best example I have of that chain of communication, which I think you're pointing out, and what you would agree, it's not really a chain of command, because Texas is a home rule state, for example, and so the cities and counties that have that have health departments, their mayors and their county judges are the bosses of their health department. So we would have to have a coalition, if you will, of the well-informed and the willing. So, but if it's a pandemic, we're talking about having to communicate with maybe 58 different local health departments and local health authorities in the state of Texas and through us, and then at a national level, you know, not only the United States, but its territories and its other interests. So that communication would be a major challenge. It will be the essential thing. I have seen it work, but I saw it work, and again, in a situation where the need, the capacity that we had in that capability of communication was not, we did not exhaust that particular capacity, so it worked well. But I think in the future it'll be a challenge, and there may, one of the first things to do up front may be to say, here's the things that we're just gonna do and take action. And here's the things that we're going to have to be able to sit and talk about.
Thanks.
Yes.
Okay, thanks. My name is Dan Rundy. I work at CSIS, a Washington-based think tank. Thank you for being here. I'm going to be moderating a panel on the role of the private sector in pandemics. And so it's a whole series of folks from the private sector talking about what they need from government. I wanted to ask you, as a representative of the government, what do you need from the private sector in a response to pandemic? I saw some comments in your slides about that. I'd welcome your elaboration on that. Thank you.
Great. Well, you know, again, one of the things that kind of informed my thinking about this is Hurricane Harvey. And so one of the things about Hurricane Harvey is, bam, it hits. You had to be prepared, and the resources that you could bring to bear on it were the resources you had already arranged to have. And so I guess the biggest thing for private industry is to be able to be involved in that planning process, so that the value that you can bring to the table is something that's already been worked into the plans. Because if we haven't rehearsed it, we're not going to execute it, and so that's extremely important.
Thank you. Great presentation, Tim Stevens. I want to take a little bit of different tack. I don't believe that the American population or any other part of the globe expect us to be able to ventilate and provide that type of care. I think the scope of what we're talking about would suggest other mechanisms. So I would challenge that a little bit. I'm not even sure that we should be pushing out that type of idea that we could do that, given the resource constraints that
I didn't mean to suggest we could.
No. I just wanted to bring that back up as a point of discussion, because I think it also goes to the other point that I'd like to, because we've discussed this already, is what is our concept of communication? I feel like we fall back on a very simplistic model. I say something, you hear it, and those things are the same. I think that's so fundamentally not the social system we work in. We make all sorts of choices about who we listen to and why. And we need to keep on going back to that and understanding that in a way that helps us allow a complex event like this to be messy and not to think we can, just offer solutions. That's my comment. But thank you, because I know you're dealing with behavioral health changes every single day, at least as complex as this.
Yes, well observed. And again, one of the lessons about Harvey is disasters are disasters because they overwhelm your capacity to do certain things. I mean, there's no way, and to the point of no, we couldn't put everybody on a ventilator, but who might need it in a very serious pandemic situation. Therefore, we need to do as much as we possibly can to keep as many people from getting that sick as we possibly can, so that we have a better chance of our capacity to do that, to match the demand for it. And as far as communication, that's a tough one nowadays. I mean, we have our own social media folks. I'm sure everyone here does. But how do you compete against Kanye West or President Trump? I mean, people are going to follow what they want to follow.
Thank you for that great reinforcement of the power of good public health. I'm John O'Quick, the author of End of Epidemics. And I've got a question about just what you're talking about, junk science and junk news. The original junk science article, which launched the vaccine autism myth, was 20 years ago. The guy named Andrew Wakefield, who's been discredited and debunked. But his impact is actually continuing to multiply. And we see it in Europe, where we've got 40,000 cases of measles this year. By the way, he lives in Austin. He escaped the UK.
It's a free country.
Yeah. Yeah. But when we look at the impact of that, and the data you showed on the vaccination, and 20% of the millennials in this country believe the myth, and 40% don't want government to tell them about vaccinations. The nightmare scenario is we have a big flu pandemic, we have an effective vaccine, and we still have an outbreak. So the question is, how do we build a collective, I don't think we have a collective strategy to combat junk science and junk news, and it's literally going to kill thousands if we don't somehow come together. And I guess, any thoughts on how to make that happen?
Boy, I wish I really had some. I guess it falls back to a principle of influence that I learned a while back, and that is nobody ever does anything for your reasons. They only do them for their reasons. And so I think if we can figure out what the reasons would be for people to get vaccinated, we'd be ahead. Now, in a pandemic situation where they really see that this is a serious matter and is really taxing the capabilities and capacities that we have in place, people might decide, well, maybe I'd better get the vaccine. That might be less risk than trying to get the disease. That is the worst reason. We want a better reason than that. We want an upstream reason for them to do it that way. But as again, it points out the fact today, uniquely, I think, at least in American culture, it wasn't the American culture I grew up in, where there were ABC, NBC, and CBS, and you could go talk to your neighbor about I Love Lucy that was on TV last night, and you had this common cultural whatever, as limited as it may be. Today, you don't have to listen to or believe anything that you don't already want to listen to or believe. And so you can completely shape your own world and your own worldview and find plenty of people who are willing to share it with you. And how exactly it is that we try and combat that with facts and with science is, I think, one of the major challenges that we have, not just in this area, but in other areas of our society.